And that time is now. It's another Tuesday. It's a bit past 11 a.m. this morning, and we're getting straight into the conversation today on Today in Global Health. Last week, a lot of you are giving feedback, talking about how it was informative and how it touched on different aspects of health that you normally wouldn't have other health programs discussed. And that's why we are called your station, the information, a home of information. And that is why we call Lagos Talks. We don't just talk normal talk. We talk based on research and things that are transformational and developmental in nature. The co-host is here with me again today, joining us all the way from Canada. Professor Uche Ongwaba is with me. Good morning, Prof.
Good morning. It's a pleasure to be here again.
Great to have you join us this morning. And we're talking this morning, strengthening, we say regional health governance. I mean, there's so much about around health that is beyond the pills, the malaria sicknesses and all that that we're used to here. So talking about regional health governance. Well, let us know a bit more about that as we get into today's conversation.
Okay. Thank you, Coyote. And so I suppose that for many, it would be a very unusual framework, regional health governance, because I suppose many will not be familiar with that concept beyond probably WHO regional offices. Now, the idea behind our conversation about uh, focusing on regional systems or a regional health governance framework is tied off, if you recall the conversation we were having last week about, what is global health, and part of that conversation revealed that global health indeed is a constellation of systems that come together to produce, what we experience in terms of health. And then one of the problems we identify with global health was the dynamics of power and colonialism. And so the focus on the regional health governance approach is informed by the thinking that perhaps if we strengthen existing structures at the regional level, in Africa, we have the African Human Rights System, the African Union, already doing very phenomenal work in integrating the continent. You have the African Continental Free Trade Agreements trying to power trade in the continent. You have Africa CDC trying to show leadership on the continent in various domains of health. And these are specific issues, specifically the Africa CDC, that we will be speaking to in our discussion today. And so the idea is that if we concentrate and build capabilities at the regional level, perhaps we'll be able to address some of the shortcomings of the global health governance architecture, some of which were evident in our conversation last week. And I guess we're going to speak more about some of these shortcomings in this discussion today.
And truly, we will. And with every single interaction that we have on the Today in Global Health, it further lends credence to the fact that no nation is expected to go it alone. You need to be working as a team, either in clusters, in regional clusters within your continent, or as an entire continent before you now even morph to the global stage where you could have that maybe a centripetal force controlling everything from that space. But we'll get to introduce our guest. It is Today in Global Health. So let's bring you two other panelists. I'll be joining the Professor Uche Ongwaba this morning. We start with Ada Salim. She's a project manager and global health researcher with a track record of leading transformative healthcare projects and advancing population health initiatives. She holds a master's in global health from McMaster University, where she explored refugee health promotion in Canada. Ada currently supports the regional health governance study as a project manager and research assistant to Professor Ongwaba, contributing to the scoping review and co-authoring the inaugural research report. Her work has also been published in the Journal of Racial and Ethnic Health Disparities, examining primary care access among racialized communities in Canada. Ada previously served as a project manager at Mackenzie Health, co-editor-in-chief of the Global Health Annual Review, and president of the World University Service of Canada. Now, our second guest is Jasmine Bassey, who is a doctor candidate at the Lincoln Alexander School of Law in Toronto with a master's in political science from McMaster University, specializing in global politics. Her graduate research on nation building and identity in post-colonial India was showcased in the 1984 Path of the Warrior Saints exhibition, curated by author and poet Rupi Kaur, and was most recently presented at the Stakeholders Conference at Stanford University. She currently serves as a summer law student at the Canadian Civil Liberties Association and as a research assistant to Professor Ngwaba, studying regional health governance and equitable pandemic management in the Inter-American system. Jasmine also brings prior experience as a political staffer and government relations professional. Of course, that of Dr. Uche Ngwaba cannot go unnoticed. Commenced his academic career as a research fellow at the Nigerian Institute of Advanced Legal Studies in 2010, subsequently proceeding to Sydney, Australia to undertake his doctoral studies. His doctoral research utilized a comparative method to explore how human rights framework can strengthen Nigeria's health system to achieve universal health coverage. Before taking up his current appointment as an assistant professor at the Lincoln Alexander School of Law in Toronto Metropolitan University in Canada, Dr. Ngwaba taught as a sessional lecturer in 3 Australian universities for about 5 years. Wow. He engages critical human rights perspectives and post-colonial theories to examine how health governance and regulatory systems impact health outcomes in global North and South. Dr. Ngwaba currently leads a program of research focused on advancing a regional health governance approach in the Inter-American system. So today, we're talking about the importance of regional health. To my guests, Professor Uche Ngwaba, Ada Salim, and Jasmine Bassey, welcome to the show and welcome to Nigeria.
Thank you.
Great. So now you've given an outlook on what global health or regional health governance really means and how important it is for us to come together into one cluster. But while it might look self-explanatory, regional health governance, I'd like you to drill down, further down into the necessity or the importance, the benefit of having a strong regional governance framework in Africa, as an example. And let's also know if we've ever thought of it, if we're working on it now, or where are we with that case. Prof, over to you.
Thank you very much. And so a good way to begin this is to say that in the aftermath of the COVID-19 pandemic and the response to that pandemic, there were a lot of gaps and paralysis in the system of global cooperation for health. When we talk about health governance or global health governance, the WHO sits at the pinnacle of that structure and is responsible by virtue of the WHO Constitution and other international human rights instruments and treaties to, drive global responses to epidemics and pandemics. Now, what we observed during the COVID-19 pandemic was that the WHO was unable to really drive that process of governance within the framework that was embedded in equity. When we talk about equity, what we're referring to is a system where states are able to expect saneness in treatment and opportunities to be able to respond to the crisis. And they are going to expect or able to expect that existing laws, institutions, and mechanisms in the global order serve to protect the citizenry of the states in the global north. We've been using this expression very frequently in our exchanges in this program.
Yeah.
The global north referring to the West, referring to the developed world, while the global south referring to the developing world or to the under to or to what we not sometimes refer to as third world countries or developing countries and so on and so forth. So those expressions actually that's what they mean, the global north and the global south. And so to the point where we saw how institutions and mechanisms in the global order catered to the interests of the global north and global north countries differently to the way it catered to the global south and global south countries. And keep in mind that there are already existing structural differences and inequities and incapacities in the health system of many global south states. And so what we saw was an absence of equity or solidarity. Now, listeners might be wondering what obligations did global North countries have or owe to global South countries to be able to help them better respond to the pandemic? And my simple answer would be that there are treaty commitments. The International Covenant on Economic, Social, and Cultural Rights is one of the major treaties in the world that has imposed obligations on states. Article 2.1 of that treaty provides in particular that states should assist other states, states that are more able and more capable, should assist other states to be able to progressively, realize their obligations under the treaty, including the rights to health. But we saw during the pandemic, states conveniently abandoned these commitments to do, equity by providing access to, the technologies and to the outputs from research, such as vaccines and patents to vaccines to be able to have this readily available to citizens. And so our research has done a lot of mapping and tracking of occurrences during the pandemic, where you would see that, midway into the pandemic, while global north states were boosting the vaccination of their population, that is, they had vaccinated their population twice, and we're now administering a booster, and Canada was one of such countries. In the global south, less than 10% of the population had received the first dose. Many frontline workers in the global south had not even been vaccinated at all. So, these things are very recent in our memory. I don't think I need to sort of rehash these occurrences. I think no one knows it better than people living in Nigeria, the experiences with having access to the COVID vaccines. And so, building off this, situation, we are saying that, look, you can never trust that if another crisis happens, we are not going to face the same sort of situation where we'll begin to have countries in the global north, exhibiting what the WHO Director General called vaccine nationalism or vaccine apartheid, abandoning long-standing commitments to be able to contribute in solidarity towards the progress of less developed or global south states to be able to meet their health demands. And so our research and our work in the regional health governance studies essentially saying, how about we develop our own systems and structures in the continent through a regional health governance approach? And
Right.
already there are existing institutional frameworks that we think can be repurposed to be able to achieve this objective. So
Hmm.
let me just stop there for now.
All right, and it's good you said this because when you were listing all this, one thing that came to mind in terms of the likely benefits of a strong regional um, health governance structure is in our part of the world, we often wait for the global north to conclude their research on certain vaccines, on certain studies, health studies, before it is cascaded down to our side. So we are often like at the receiving end. We're not priority. Now, whether it's malaria, even recently we just heard of some vaccines created for malaria after how many years we couldn't do this ourselves. Now, if we were to have a regional, a regional health governance structure, well put in place in Africa. Is it possible? Will it be advisable to fashion out our own approach or medical care approach, for example, deciding to focus on tropicals rather than the what we call the orthodox or what we know as medical care today, in terms of doing research, going the way of the China, the India, using a plant-based to, manufacture drugs. I don't know if I should go to Ada Salim on this or Yasmin Abbas, because Ada seems to be more moving. It's like she's itching to address this. Let's go to you, Ada, then.
Thank you. So I'm a really huge believer as a project manager in not reinventing the wheel. I was kind of reminded about this yesterday when I had to go get food to one of my favorite restaurants. There was an option to add Doritos to the food.
Okay.
And my husband looked at me and he's like, "We have Doritos at home. Why are you itching to go buy and spend another $7 on Doritos when we have it at home? We could crush it up at home. We could crush it up in the way that we want to. We could spread it out the way that we want to. We don't have to ask someone else to do that and pay extra for that." So in the same way, when it comes to medical care within a certain region, the persons who are actually living through this and living through the actual healthcare crisis, who are experiencing those wait times at the hospital, those who are the staff, the frontline staff who are experiencing the shortages in particular resources or expertise that has been kind of brought in from different universities within the actual region, they would be the ones that would be the strongest advocates for that population. And because of that, it's a lot more beneficial for them to use that local knowledge to be able to produce equitable outcomes for that population in a way that is meaningful and a way that is sustainable. And that's generally the basis of population health equity in essence. And that's one of the key concepts that the regional health governance study is going to be tapping into, and bringing back agency to those regions that would have already had these solutions, but may not have had the actual platform to be able to showcase that or the additional support needed.
I think I just like to emphasize that a regional approach designed around Africa's social political realities and health needs can really foster greater solidarity by mobilizing states accustomed to collaborating in solidarity to collectively and equitably address the shared health threats. And unlike the top-down global system, regional governance can empower African states to collaborate more meaningfully, share resources, and shape context-specific responses. And as our regional health governance study suggests, regionalism offers a way to decentralize decision-making and respond with greater agility and equity to these health crises. And that's why I think the regional health governance model would really be beneficial. And this is kind of what we're exploring with our study.
All right.
Let me quickly shed a quick light to add to what Jasmine and Ada have said. And this is just a very quick observation. There is something in the vocabulary of of global health called forgotten tropical diseases. I don't know, you probably must have heard of it, and many would have heard of it, forgotten tropical disease. And people go and study it. And my very simple response to them is diseases are not forgotten. You cannot forget a disease. The people who are experiencing these diseases do not forget them. So what if they are not forgotten, then what is it? What exactly is the situation with those diseases? Well, my simple response would be they are simply ignored. The diseases are not forgotten, they are simply ignored. So because they are in the tropics, that is the global south, it is convenient to forget them because it doesn't affect the populations in the global north where these diseases should not be found. And that's why you sometimes find people will say This is not like when something happens, they'll be like, this is not some third world country in Africa where this kind of things should be happening. Do you understand? So you frequently hear this sort of expression. And so that speaks to the point that Ada and Jasmine have made, which is to say, look, if we have regional structures, we're able to sort of focus on the things that are priorities to us. Like, for example, in Nigeria, malaria is a huge problem. And so we'll have resources devoted towards malaria research. In Canada, malaria is not a problem at all. Like, they don't have malaria, so why would they develop billions of dollars?
So they have no compulsion to commit such huge amounts to research. It's not there.
Absolutely.
It's not a problem. Yes, but when you look at this, I'm just being an average citizen here who wants solutions. An average citizen who sees how the West, the global North, often plan ahead and look for solutions to challenges. And you're compelled to ask one question. So, all these years that we've been confronted with the likes of malaria, which is the most prominent, the most common disease, and there are other diseases, though, or illnesses that we have that we just has become part of us. For example, typhoid now. You go to a hospital, we don't like going to hospitals here. You go to a hospital and you realize that you've had, when you're diagnosed, you have malaria plus and typhoid in your blood, in your stream. And all these things do happen. Now, the question is, what have our leaders been doing all along? When we talk of healthcare, where are we with a regional health structure? I know we have the Africa CDC. I know we have this global health repository stuff. I think is in Kenya or somewhere, the World Bank, World WHO rather, and all that. But in terms of our own structure, where are we with it as at today?
That's a very interesting and important question you've asked, Coyote. And I think it is very important that we establish where we are in sort of like the broad geography of this sort of discourse. Now, the position is that there is currently there are beginnings of what can look like a regional health governance framework. With the work of the Africa CDC, the Africa CDC began actively acting in its current role in 2019 or thereabout, was probably the constitutive, policy instrument to have been dated earlier. And what the Africa CDC has tried to do, it has tried to step into a vacuum of leadership. During the Ebola crisis, there was a vacuum of leadership. The WHO failed to trigger the declaration that the Ebola pandemic was a public health emergency of international concern. Triggering that declaration would have meant that the global community would have diverted resources towards Africa, West Africa in particular, to be able to respond to the crisis. But the WHO did not do that. Now, Africa CDC has come on the scene and taking up the gauntlet of saying we're not going to wait for the WHO. If we see a crisis that is happening on the continent, that is affecting the continent, we're going to do something about it. And so, for example, in 2024, when Mpox, the monkeypox virus, was happening again, Africa CDC, preempted the WHO and declared the Mpox breakout to be a public health emergency of continental security. Now, I throw in this example to illustrate the point that we do not have a very established framework for regional health governance at the moment. However, we do have the essential building blocks for such a framework. In the Inter-American system, where our research also focuses on, we do not have a framework called a regional health governance framework. However, we have the essential building blocks for such a framework through the Pan-American Health Organization and the African and the Inter-American Commission, which are already doing work related to sort of deepening and strengthening health. Now, what does this mean for and that is to the other part of your question about Africa's capabilities to drive public responses, and the responsibilities on our leadership to be able to put in the resources, the time, and the manpower towards achieving that. Well, the simple response is this: ultimately, the role of the state with respect to health is to strengthen the capabilities of the populace, the citizenry, to be able to pursue, healthy life, achieve healthy lives. And in the event of the manifestation of a health crisis, the role of the states is to ensure that there are, systems, institutions, and structures in place to allow the citizens to be able to meet the challenges arising from those health situations. And so we cannot work within a system where there is now the manifestation of transnational health threats if we do not develop capabilities for transnational responses to transnational health threats. It is not right that whenever there is a health crisis, there's a breakout of, say, monkeypox in East Africa, Ebola in West Africa, we would be all paralyzed, once we have to frame a transborder response to the crisis because we have to wait for the WHO to channel resources, or we have to wait for Western countries to be able to devote resources so that we can be able to do all of that. We need to get to a point where we can, as a continent, fashion our own responses, decide what is our priority, and work towards achieving those priorities, focusing resources where they should be focused on, determining where there are gaps that need to be addressed. Because sometimes some of the gaps might be issues that the Western states do not care about. For example, it could be an underlying determinant. For example, housing, for example, food, for example, shelter. So there could be things that the Western countries, because Western countries, even when they bring donations or when they bring resources towards this crisis, they want a quick fix. They want a quick win. They want something that can appear in their next progress reports. They're not interested in building institutions and structures that can endure. And so the regional health governance framework or approach is fixed on addressing the structural paralysis that hinders global South countries, African countries, from being able to be to take agency, as Ada said in her own intervention, agency over their health situation.
All right, and with this now, from your explanation, it means that we might be unable to develop a very functional, robust, responsive regional health governance system or structure if we do not improve on our communications, our interaction channel, and develop a sense of understanding amongst ourselves. From the AU, or let's even break it down into smaller units. The regional blocks, West Africa, SADC, and the rest. Do you see any structure that facilitates movement? We know in West Africa we have free movement of people and goods, but beyond that, the sharing of information, the engagement, are we on the same pages or the same page with our understanding of certain diseases, or are there still variation? Are there things we need to align in order to make this regional governance structure robust?
Let me first address this point, and I'll give the floor to Ada to talk about some of the things she's finding from the work she's doing, coordinating this research at the inter-American level. Now, speaking to the African Union context, it is very unfortunate, Coyote, that on the continent, we are supposed to be brothers and sisters on the continent. We share, the same common. Many states in the continent share the same common histories of, colonialism, slave trade, post-colonial exploitation by Western states. Yet, we are so divided on the continent. It will shock you to find out that it is easier for Nigeria to trade with the UK, to trade with America, than for Nigeria to trade with, say, Kenya or Tanzania or Rwanda. It is easier for a Nigerian to travel to Europe than to travel to an African country. Sometimes to travel to a country in Southern Africa, you have to go, if you're traveling with a foreign airline, you have to fly out of the continent. I met a particular individual who was telling me that he was going to Ethiopia, but then he had to fly to Doha or somewhere to come back to Ethiopia also. it was so ridiculous, listening to, that account. And so what am I saying? I'm saying that in the continent, we do not have sufficient coordination mechanisms in place. We have obviously the institutional structures, the African Union, the African Human Rights System, the AU Commission, the African Union Commission, the AU courts, the African Union courts, the Africa CDC, which is a directorate of the African Union. Then you have the African Union Development Agency. You have NEPAD, the New Partnership for Africa's Development. There are structures that have been put in place to encourage solidarity, to encourage government to government and people to people solidarity. And these solidarities are manifesting in different places and in different spaces. For example, in the border communities of Nigeria, communities between Nigeria and Cameroon are already exhibiting solidarities between themselves in trade, formal and informal trade, and so on and so forth. What we do not have is an organized mechanism for coordination, for devoting resources towards, targeting specific problems. I think you mentioned in your initial monologue that Western states have this ability to plan ahead and to commit time and resources to fix paralysis in their system. Why we don't have the same on the continent? We seem to live for the moment. We're like that neighbor that when he's paid the salary, he spends it in a beer parlor or something like that. He consumes everything. He says, "Let me leave today. I don't know whether I would survive tomorrow." And then tomorrow he of course survives, but he doesn't have any money because he hasn't prepared for tomorrow. So we're like that particular neighbor who does that on the continent, and it is not because we don't have the capacity to be able to plan. Africa's human resource in health is exponential and largely responsible for the good health outcomes you have in Canada, the UK, the US, Australia. Matter of fact, these countries, whenever they have gaps in their health system, they go and change their immigration policy to have a skilled worker migration for health workers. They target our health workers, harvest our health workers from the continent to go and support the health system. So we already have this, capacity. Okay, we have the resources. Africa is the richest continent in the world. Many Western countries will be in crisis without the resources from the continent. So what is missing is the leadership, the planning, the organizational initiative to begin to sort of pull all of these resources together in a very sort of sophisticated and coordinated way to achieve target objectives. Now, Ada, probably you want to jump in and talk about the inter-American system.
I think one of the lessons that we've been learning from the inter-American system is essentially this culture of urgency. And why does a regional health governance system matter? Why is it that we need to communicate better? Why is it that we need to organize better? It's because healthcare and diseases that are also tropical diseases from the Caribbean where I'm from. So I think the African region and the Caribbean can relate and can share a lot of trauma where that is concerned, is that these diseases can impact your parents, they can impact your children, they can impact your spouse, they can impact your auntie, your uncle, whoever it is, right? Because it doesn't matter which part of society you're from. You could be from civil society, you can be from the upper levels of government. It's going to impact you in some way or another, right? And it's that sense of urgency is what's going to drive the urgency to be able to create something a lot more organized. And through the research that we've been looking into, through the different policies and programs that have been implemented within the region, we see this common sense of urgency. And that is what is going to propel the region, African region, to be able to become more empowered, to take back more agency. In addition to that, there's also a term called legal epidemiology, which is something that I kind of played upon in my research, and it's something that we're actually actively looking into in the scoping review that we're doing right now with the Regional Health Governance Study. And this particular term essentially means how laws and policies have informed the capacity building of collective health equity, and the well-being of a population. So it's looking at how laws within the region, international laws as well, and how that has kind of been impacting the health of several populations, whether it be through translational policies that are coming top down from the government all the way down to frontline patient care, and what the impact of that is going to look like in terms of the near future. So we saw a lot of that when it comes to how refugees are being treated within Canada, how refugees are being treated in the US in terms of their health and their health priorities. And taking the lesson from that and how we're going to build a regional health governance system, we have to be able to look at governance as also a legal entity in itself. And that's why our study is looking at different treaties and different laws within the region of the inter-American system, and how that is either going to be improved or how we can be able to enforce some of the existing regulations within those policies to be able to drive something a lot more meaningful when it comes to regional health governance. Jasmine, would you like to hop in a little bit?
All right. Before Jasmine comes in onto this, we need to take a short break. But even before that, all what you've said, it's right, spot on. But I actually have a question in addition to what Jasmine's contribution is going to be. I mean, I'm directing that question to her based on her background in global politics. I'm right? Jasmine on that, right?
Yes.
So yeah, so in terms of global politics, my question here, which is also a worry, is that could global politics be playing a role in Africa's inability to coordinate a very robust regional health governance structure? Because if we are self-sufficient and we don't need to rely on any, well, I don't know if we can ever get to that. Anybody in the world can stand alone without relying on any support from any other part of the world. Wouldn't that mean that then we're creating our own market, we're producing our own pharmaceutical products, we're strong enough? Could global politics be playing a role in this? But you will answer that question when we come back from this break. Do not change your dial. Lagos Talks 91.3 FM. This is Today in Global Health. We'll take a short break right now, and when we come back, the conversation will continue right here. My guests are Jasmine Bassi, Ada Salem, and Professor Uche Ngwaba, all from Canada, and Today in Global Health, bringing you updates on what really we have, or what really we mean when we talk about the importance of having a robust regional health governance structure. Do not change your dial. We'll be right back. All right, welcome back to the studio right here at Lagos Talks 91.3 FM. We'll be wrapping up the show real quickly. But before we went on that break, we had asked a question of Jasmine, talking about the role global politics is playing in restricting or making it difficult or impossible to create or coordinate a very robust regional health governance structure. Does that play any role at all?
Yeah, thank you. So global politics profoundly shapes Africa's capacity to build an effective regional health governance model. And we've discussed this before. Professor Nkwaba brought this up. The power asymmetries are really important to bring into this conversation. Rooted in historical colonial legacies and reinforced by contemporary global economic structures. All of these limit Africa's autonomy in setting its own health priorities. And again, we saw this during the COVID-19 pandemic as well, and where wealthier nations were able to secure early access to treatment tools, testing equipment, and vaccines, while African countries struggled to procure supplies. And we saw little support for states which had a lack of adequate infrastructure as well, which also impacted vaccine rollout. We saw this, for example, in the Democratic Republic of the Congo in early 2021, where 1.7 million AstraZeneca doses went unused because there wasn't adequate infrastructure to support vaccine rollout. So global politics definitely plays a significant role, and we need to have that conversation on the inequities that come from the historical and contemporary disparities. And as our regional health governance study discusses, decolonizing global health requires these regional models that shift decision-making closer to the affected communities and resist the dominance of institutions which are shaped by the interests of the global north. And so for Africa to lead its own pandemic preparedness strategy, for example, it must navigate and challenge these global power dynamics while strengthening intra-African solidarity and cooperation. So that's a very long-winded way of saying global politics definitely plays a significant role, and this conversation needs to be had when developing a new regional governance model.
And hearing you say this, I don't know if to call it dashed hopes or I should just limit my expectations, because if global politics plays such an important role, not running down Africa or any other country, but the question then is, are our leaders ready to play big at the table when it comes to global politics, such that they will make certain demands and play, they have, just play ball the way it's meant to be played, so that Africans can be considered favorably in terms of global politics. But having said that, since we are where we are and we know the impact of global politics on the getting a robust regional health governance structure, can we start? Is there any benefit in starting by collaborating with other regional structures? Maybe we could leverage on that first of all, then we gradually build ours, and when we've grown, to that level, we could then fully establish. Prof, what do you think?
Absolutely, Kaide, you're right. There's a lot of benefits that can come from inter-regional cooperation between, for example, the African regional system and the inter-American or the European Union system. Although I would also be very cautious in getting into those sort of collaboration, because some of those other regional systems are the site of exploitation. For example, the European Union system is a site of power. The inter-American system is a bit complicated because it's both a site of power and also a site of exploitation, because the Americas are not a monolith. You have some parts of the Americas that are third world. You have other parts of the America, like Canada and the US in North America, that are part of the global order of exploitation. But having said that, and feeding on and building off our response by Jasmine, the commitments to a regional governance approach is reflected in the aphorism, or is reflected in the understanding that power is never given, it is taken. If you feel that the colonial structures have suppressed your capabilities and ability to function, then it is your responsibility to dismantle those colonial structures. And the regional health governance framework would allow African states to dismantle those structures of coloniality that are very deeply embedded in global institutions. I mean, the point we're simply making is that African lives don't matter the same way that Western lives matter. I wrote an article after the pandemic. It said, "Taking third world life seriously." That's the title. That was the opening phrase of the article, "Taking third world life seriously." Because I looked at the situation that was playing out, with the COVID response and all of that. And I came to a very grim realization, which is that as Animal Farm said, all animals are equal, but some are more equal than others. All lives are equal, but some are more equal than others. Or all lives are important, but some are more important than others. And that was just a simple realization I came to. African lives don't really matter in the grand scheme of things. And so if we want our lives to begin to matter, then we need to do something about it by seizing those structures of power, dismantling them, and creating the kind of structures we want to see. This is what I call decolonization by praxis. That is decolonizing by doing it. You're not waiting for somebody to give it to you on a platter, because that's not going to happen.
Mm. Well, we need to take steps ourselves. Nobody will hand it over to us. And well, when we look at this right now, we've spoken a lot about the challenges we've had and how there are limitations. But from your view, and I'd like all three of you to speak on this because you've all done researches and you're all coming from different backgrounds and knowledge scope on health and the global north and south. What are the basic steps we need to take right now if we want to begin to strengthen regional health governance in Africa? Should we begin in clusters of sub-regional, or should we focus on the global, the general regional African continent? Or, and if we are doing any of these two, what are the basic steps to do? Do we begin to bring back people like Professor Uche Ngwamba and look for a company to just pay you your salary because government cannot afford it? Or how do we do this so that we could build this structure?
So it's a very important question. Let me go first, and then I'll give the floor to others. I will use a very simple word to describe what we need to do: solidarity. This is a word that at the global level, they always sort of throw around. Well, we need to do solidarity, solidarity. What does it mean? And so when I say we need to do solidarity, we need to engage more with solidarity, it's simply based off this idea that it is easier to do solidarity with your neighbor. Because if we understand that on the continent we're all neighbors and we need to be good neighbors to one another, then that would drive us to be able to sort of put the commitments on place to be able to do this. As I've mentioned earlier, it is not the case that we don't have the capacity, the intelligence, the capabilities to do this. It's just simply the case that we just haven't put our mind to it. African countries, African states, as an ecosystem, we're so divided. We need to do more to sort of work together. That's a place to start.
Okay. All right. Let's go to you, Jasmine Bassi.
I agree. I think solidarity is the place to begin. And I think there are some key mechanisms also that we can focus on when trying to establish that solidarity, that focus on ensuring accountability and coordination among the African states. And these include standardized legal frameworks across states, which will ensure consistent responses. There can be shared financial mechanisms, which reduce fragmentation. And there can also be this robust monitoring, which ensures transparency and compliance. And these key mechanisms are a good place to begin. And these tools create a cohesive, accountable architecture that enhances coordination and responsiveness across borders. I think that is a great place to begin.
Okay, that's good. Let's go to Ada Salem.
Yes, my colleagues mentioned really well about the tools that can be adopted through solidarity. But the only way that this can be facilitated is through communication. We have to talk to each other. We have to be able to get on platforms like this, to be able to inform that discussion, to drive that knowledge, to go to different states, different types of actors, whether that be through civil society, whether that be through the government, whether that be through researchers, whether that be for the private sector, businessmen, businesswomen who might be affected by this in some way or another. You can't say that, oh, my business doesn't concern this, is a whole different area and it's just not going to affect me. It's going to affect you in some way or another. Health policies always affect someone. So we have to be able to create that sense of urgency through communication and to be able to uplift marginalized voices within those states as well. Those that might be drowned out, those that might be the most impacted by healthcare policies within the region.
All right, then.
And the only way to do that is through communicating. Yeah.
All right, great. So all three agree on one thing, that be more collaborative and less competitive. And that is how we could grow together as Africa and have a strong, a very robust regional health governance structure. Thank you so much, Prof, for your time today. Prof. Uche Ngwamba, Jasmine Bassi, and Ada Salem for educating us this morning. Like we say, it's a school. Thank you for your time.
Thank you.
All right. And that's how we wrap up the show this morning. We say thank you to every single person who has been part of the conversation that we've had today. It is time for us to leave the studio, and we leave you in safe hands. We hope that by listening to us and attempting to influence all the decision that all what we've said, our health will get better. My name is Olu Akade. This has been Today in Global Health. Up next is the World News at